Bless you.
Thank you.
Dosimetry and treatment planning are the same thing. Right. In some departments it's called treatment planning, other departments it's called dosimetry. It's the same thing. So, treatment planning is tasked to make sure a prescription is put into practice in an authorized way. So you have, thank you, you have the oncologist who does the prescription is given to both dosimetry or treatment planning and to CT. Because CT is actually the start of treatment planning. So we do planning, and then we do treatment. Okay. So patient information required. What do you need? You're in CT. What do you need from the physician? Or what would you think you need from the physician? What information do you need before you put the patient on the CT bed,
What you're scanning.
do the scan?
What you're scanning. Yeah.
Well, two things about that.
Oh, okay.
What the diagnosis is and what area are you scanning. So the diagnosis could be carcinoma of the cervix, but you're scanning spine because the patient has got metastasis to the spine. So, if you have a lady on the bed, or you're about to get the lady on the bed for a scan of the pelvis for carcinoma of the cervix. Let's take you right back to the beginning. What information do you give the patient before they start the scan? What questions do you ask the patient? You're going to put her on a CT scan, or CT scanner bed. Okay? What do you do if she is, or should be, or could be? Consult the physician. Okay, we'll presume she's not. Okay? Just since you brought that up, what age group would you ask that question? From which? What?
I mean, age 10 to 50s?
Age 10 to 50?
Assuming whatever, if they've started their cycle.
Yeah, okay. From basically menarche to 50? Would you agree with that? 50?
At Orange Park, they do it until 60.
Because it is possible, depending on when you go into menopause, to still be pregnant at over 50. So yeah, 60 is probably reasonable. Okay, so that's that. And if they're unsure, you send them for a pregnancy test before they do anything else. Okay, so apart from the pregnancy question, what other information would you give them, and what information would you need from them? Perhaps, have they ever had a CAT scan before? Because you're gonna put them on a CT bed, do they know what they're gonna have done? If they've never had a CAT, if they've never seen a CAT scan, you have to explain what it is and what it looks like and what it does. So somebody tell me in words of, that could be understanding someone from 5th grade education. What's a CAT scan? It's actually easier to show, but they've got somebody on the bed in the CAT scan at the moment, so you can't really show them what it is, but what would you tell them?
Special machine that takes many pictures of your jaw.
You could probably use x-rays. Internal anatomy, you might, depending on the patient. X-rays of your inside. And what do you tell them about the donut? Everybody knows what I mean by the donut, right?
I'm just gonna go through it, but nothing will touch them.
Yeah, you're gonna go through a tunnel, but you're gonna come out the other end. And nothing's gonna touch them, nothing's gonna hurt them. It may make a noise, et cetera, et cetera, et cetera. Okay. So,
I had one patient. I've never seen anything like this before.
okay,
Morgan will probably see her
you
soon.
can always count on Asia for a story, yes.
Cause we do this, I'm in the CT scan room or whatever, and the doctor came in to wire the two.
So, we digressed. So you want to make sure that the patient knows what they're going to have done. So next question is, what did the doctor tell you was going to happen today? Because normally the doctor will say, well, you're coming for a CAT scan and this is what's gonna happen, and explain. And you hope that the patient has been explained to. But do they remember? They've signed a consent form and the doctor has explained everything. And they sign it. And then the next day you come up and say, the doctor, no, doctor never told me anything. So this lady is a cervix. So what are you going to tell her that you're going to do at the CAT scan? I'll start you off. You're gonna lie on the bed. Okay. But oh, by the way, is she dressed?
She's only waist down. Is this the one you said had meds or does not?
No, this is a cervix. Is she dressed?
I think so. She's had one.
She can pull her pants
Depending
down
on
under her butt.
the department, 9 times out of 10, you put them in a gown for the CAT scan. Because the patient, the doc may want her scanned from here down to here. So it's easier for them to take off from the waist down on a gown. They can leave their bra and stuff on, but from there down, and make sure they do put a gown on, don't wander out of the room half naked. So you get them into the gown, you lie them on the bed. How do you position them? And what do you tell them you're going to do? Sorry?
They go on the back lock, but they get a pillow.
Define pillow.
Oh my god.
Black headrest?
Yeah.
Is that a normal,
No, the blue
Pillow,
headrest.
pillow?
The blue headrest.
okay, a headrest? depending on your department protocol, it can be several types of headrests. Right.
Too many questions.
Then what? You
Then,
make the vac lock. What do you explain, how do you explain to the patient the vac lock?
it's like a beanbag.
Which does what?
We suck the air out of it,
Mm-hmm.
and
Warms to your body.
it tightens around your body that we are forming it
Mm-hmm.
around your lower half.
Is
Which
it
is the
gonna hurt?
purpose, right? No.
Okay.
It's just gonna feel tight.
Okay.
Um,
So, what do you do with our hands?
on your chest.
With?
It can be with a ring, but it doesn't always have
Yeah.
to be.
If you have a ring, put a ring there. If not, what do you do with our hands? Just clasp them. Yeah, over the chest. Yeah, not down here. Up here. Why not down here?
Because of reading scan.
So then you explain to the patient that you're going to put some marks on. And you know that the CT has lasers, right? So you point out the lasers and let them know that they're going to be touching. You're going to be touching them to put marks on. The lasers are going to come over and you're going to position them to match the lasers.
Then you put the BBs on.
Pardon?
Then you put the BBs on after you get your mark.
Yeah.
So,
So
it doesn't show up on
in
the scan.
CT, do you put the marks on before you turn the, or before you use the lasers, or vice versa?
You can't. You can't. Your lasers are where you find your spot.
Mm-hmm.
Then you mark it with permanent marker,
Right,
and then you put the BBs on it.
right. That's
Because-
exactly what it is. So you line them up and make sure they're straight, right? You go to the end of the bed and you look at them. Make sure that they're straight. You have the sagittal laser that should go down midline, because remember, the CT bed does not move lateral. You have to get them centered. So get them centered as you can, as much as you can. Then put the lasers on to where you think your cervix is. So it's usually midpoint here. So, and then you put the marks, you make sure the lasers are on, then you put the marks on. And then you put the BBs on. So what are the BBs called?
Are they fiducials? Like
Fiducials. Fiducials. Yep, fiducials. So you're making sure that you're scanning the patient from, depending on what the doctor wants, if he or she wants it from here down to the knees, that's what you scan. They may want it from umbilicus to mid-thigh, that's fine. Whatever they want, you do. So the first thing that you would do for the CAT scan, before you actually scan them, means that you were in CT.
Before they're in the room?
No, they're in the room, they're lined up. Before you actually do this, the actual scan, what do you do first to make sure that they're straight? You've eyeballed it.
You just eyeball it.
You've eyeballed it. Think about it. You get there in a sec.
I
Okay.
think we just eyeball.
Hmm?
So I think we just eyeball it.
Who else has been in CT?
Or there's like this scan that you can do before the full scan. What is it called? Scout. Yeah.
Scouts. Thank
You can do a scout.
The scout. So what does a scout do? Usually it's just an AP scout. Sometimes a lateral, but that's usually for head and neck.
Sometimes we also do that if like we're trying to see if they have a full bladder or something before
Yeah.
they actually do.
Yeah. So what does a scout do? Well, what does a scout, first of all, what does a scout look like? Looks like a normal x-ray. It's showing you whether the patient is straight, especially if you're doing something like a chest and you're looking at spine. The head and neck can be great, the pelvis can be great, and the spine's like this.
Sometimes you can tell if they have scoliosis.
So you try to get the patient as straight as possible, but if they have a scoliosis or something, there's no way in heck you're gonna get them straight. So you get them as straight as possible and then do the scan. So, what one needs to know, target location, we've decided that that's cervix. Target volume and shape. You'll see that when the CT gets done and it gets sent over to dosimetry or planning. Secondary targets or potential tumor spread. So do they have any nodes? Are you treating lymph nodes? Or are you just treating the tumor itself? Location of critical structures. Okay, for cervix, critical structures or organs at risk. What would be the critical structures for cervix? Pardon?
Ovaries.
Ovaries, okay. Anything else?
Bowel.
Which valve? Okay,
Really small? I guess it just depends on how you're all shoved up
Yeah.
in there.
right, okay. So we'll say large bowel, colon, rectum. What else? Bladder?
If you have a dark eye.
Yeah. Okay. So volume and shape of critical structures and radiobiology of structures. So why is that important?
To know how much each area can handle before it starts to be affected by
So- So you need, yeah, okay. You need to know what the type of, whether they're sensitive, how sensitive they are to radiation or otherwise. So you all know this, so I won't spend too much time on this. Here's your gross tumor volume, your clinical tumor volume, your planning tumor volume, your treated volume, and your irradiated volume. So your planning treatment volume and your treated volume are usually the same thing. And the irradiated volume is the square or the rectangle without shielding. This is a dose volume histogram. Has anybody seen these in the plan or the patient's treatment? So what do they tell you? Comparison of three different treatment techniques, red, blue, and green, in terms of dose to target and critical structures. So normally in a dose volume histogram, who has seen a dose volume histogram?
I've seen them in plants, but we try to read them.
Yeah, I feel like
No.
I've seen
So you've actually seen them in plants, okay? So this isn't a good one because it's not labeled. So what we would do is each one of these would be, say, a critical structure, like the bladder, or the rectum, or the spine. No, not the spinal cord, because it's too long. Okay, let's see, rectum, bladder, ovaries. So you have the dose here, and the percentage of the volume of the critical structure. So 100% of the critical structure would mean that you are encompassing the whole structure. Okay? So here, if you say, I want to know, we'll say the red is the rectum. I want to know how much of the rectum is getting 4,000 centigrade. So you go up here and you hit the rectum here and you go across. And in this case, it would be something like 5,500. Now these obviously aren't critical structures, or at least they're not labeled. Or we'll say the blue is the bladder. So you want to see how much of the bladder is getting 4,000. So you go up again, you hit, and obviously that wouldn't be logical to give 7,000 to the bladder. Don't be able to do that. But that's the way criticals, that's the way DVHs work. And we'll go through them a little bit further later. Does that make some kind of sense? Next time you're looking at the DVHs, or dose volume histograms, if your therapist has time, and only if they have time, and I know that's a bold move, just ask them to tell you what the DVHs mean, or show them what the DVH means. Or you can ask them for a copy with the name blacked out and bring it in and we'll look at them. Or if you can take a photograph and send it to me with the name blacked out. If they'll allow you to do that, that's only if they'll allow you.
Just trying to get us to do illegal shit.
Hmm?
So you're trying to get us to do illegal stuff.
No, if you black out the name, it's not illegal.
I
And
don't
it's
want
been
my
used-
license revoked before I even get it.
And it's for educational purposes, so that's something.
Explain that to the board.
Okay, so the ideal DVH is that for the tumor, you would 100% to the tumor, and it would be homogeneous or homogeneous. What does homogeneous mean?
Different, uneven.
Homogeneous. Exactly the same. So in a perfect world, which of course we don't live in, the tumor would get 100% of the dose and all of the tumor would get the same dose. And the critical structure, you would get very, very little. So high dose to the whole tumor and very little to the surrounding structures. But of course, we know that that's not possible. Okay. Different organs may respond differently to different dose patterns. Is a bit of dose to all of the organ better than a high dose to a small part of the organ? There's a question for you. Is a bit of dose to all of the organ better than a high dose to a small part of the organ?
Depends on the intent.
No, it doesn't. This is to the critical structure.
Oh,
This is not to the tumor. This is to the critical structure. So if you're treating, say, the cervix, since we're on cervix, I'm fed up doing prostate, so if
No,
it's
I'm
on
kidding.
cervix, and
Bless you,
you
Steve.
have to treat the bladder a little bit. So is a bit of dose to all of the organ better than a high dose to part of the organ?
I feel like a high dose might do unrepairable damage, where the low dose has a better chance of recovery.
But the low dose is to the whole organ. You're still,
I would
you're
still
still
go
doing
with
that,
first.
okay? Anybody agree with her?
Probably do that too.
Yeah, okay. Anybody else? Anybody, let's put it this way, anybody disagree? That it's better for a low dose to all of the organ than a high dose to part of the organ?
I agree with her.
Okay.
So we get radiation every day to our whole body.
Let's hope we're not all wrong.
So here is some of them. This is, in many organs, dose and volume affect some length. So if you give greater than 65 gray to 40% of the rectum, this is regions to be of high risk to be developing rectal bleeding. But if you give 70 or greater than 70 gray to 30% of the rectal volume, it might be the same as greater than 75 gray to 5% of the rectal volume. It all depends on how much dose to what volume of the structure. That's why we have these DVHs. So the physicians can look at that and say, okay, this is acceptable. It's never excellent, it's acceptable. Remember, you're a Lara.
So what was the answer to that? Was it the
It's-
first one or the
it's-
second one?
It's slightly better to do this,
To do a higher
the
dose?
higher, but then you want to make sure that you're not going overboard. You're not giving too much, because the rectum can only take so much. So you may kill off 5% of the rectum. Is that a problem? Maybe not. But if the patient has problems with the rectum at the best of times, it may be. So it's an individual thing. So, external beam treatment. We need to know where to direct beam and how large the beam must be and how it should be shaped. This is an X-ray from a traditional simulator. Obviously, this is the pelvis. These are wires that outline the square or the rectangle of where you're treating the patient without any shielding or anything. This is the crosshair. This is 2 centimeters, and then these are 1 centimeter. So you can see that this is 2, 3, 4, 5.5. So that's 11 length by 5, 6, 7. So it's a 14 by 11 field. Then you have to put shielding in. And if you're using a classical simulator, the doctor would take this image, or it should be a film, and mark on the shielding in a wax pencil. And then you would cut cerebent to match those shielding. So, diagnostic tools. So how do you define the target? You use diagnostic procedures, palpation, X-ray, ultrasound. MRI, PET, SPECT, and diagnostic procedures, CT scan, and simulator radiograph. This is, oh, sorry, the other one is a simulator. CT scan. So they may differ from patient to patient. The patient may need a normal X-ray, a CAT scan, an MRI, a PET. May require information obtained from different modalities. So they do an MRI or a PET, and then they come to us and we tell the patient they're going to have a CAT scan. And the patient says, but I already had a CAT scan. I had a CAT scan at the hospital a couple of months ago. Why can't you use that one? What do you tell them?
Things look different.
How different? What do you mean by different?
Your anatomy can move, your tumor can grow.
Okay. Is there anything that is different about our CAT scan than the diagnostic CAT scan?
Probably.
You don't want to actually tell the patient that the tumor may have grown or something
yeah.
like that, because that would just freak them out. So what is different about our CAT scan compared to the CAT scan that somebody would get in a hospital?
Did you say the ones in the hospital had curved beds, so their
Yeah,
shape would be
Okay.
different?
yeah. Anything else? So what's so different about our CAT scan, apart from the bed, that we need to do another CAT scan? It's not so much the CAT scan itself, it's the software. We can actually use our software to send the images across to the treatment planning center. Okay, target location, we'll just skip that. That's doing a contour, so don't want to do that. We'll just skip that one. Yeah, skip that one. Okay, so simulator may be replaced by other diagnostic equipment or virtual simulation. Have you ever heard the term virtual simulation yet? That's what you're doing when you do a CAT scan in the department. That's what it's actually called, is a virtual simulation.
They say vSim.
What?
They say, like it's labeled vSim.
Yeah.
So that's what
Yeah,
I mean.
vSim, yeah. So it's a virtual simulation. So what you're doing is you're doing basically a scan of the patient. And normally what happens is that you put your lasers on, you put your marks on, you put your BBs on, and then your patient gets a CAT scan done. Then you look at it, make sure all the images are good, send it electronically across to planning or dosimetry. Then what do you do with your patient? So you've done the CAT scan, you've sent all the images across to dosimetry. Dosimetry has received them, glanced at them, say, yeah, everything's good. What are you doing with your patient now?
A dry run?
So
Why? What do you mean by dry run?
The table, but not actually treat and run through the process, so that you know where your obstacles are gonna be.
Well, no, you can't do that until the plan's done.
I thought plan was done.
No. You're sending the images, you've just done the CAT scan. You're sending the images to dosimetry to have a plan done.
you tell the
The
patient,
dosimetrist has glanced at it and say, okay, I have all the information I need. Now what do you do with your patient?
tell them it's gonna take them like 7 to 10 business days to make
Okay.
the plan.
Or whatever the dosimetrist
Yeah.
suggests, yeah.
That's just what that was.
So you send them home with orders to do what?
Wait for the phone call.
And what about the marks?
They can wash them off if they have tattoos
When did we do the tattoos?
at the end.
Okay, so we haven't said that we're doing tattoos yet, right? So once you've completed your scan, you send all the images across to dosimetry. Dosimetry has said, yeah, I've got all the information I need, it looks good. You can send the patient away. The patient's still in treatment position.
You ask them, do you remember when Dr. whatever mentioned about getting those little permanent marks?
And you say, well,
So
I don't remember. So,
I stuck myself with a needle. And I have a tattoo on my finger.
you have a tattoo in your finger. How exciting.
It was a sterile needle, thankfully. I was walking over the patient to give her tattoos and it was a sterile needle. So then I said, fuck, now I have to go make another needle for her. And I
And you
walked
put
back
the needle into the
the sharp spin.
sharp spot.
And then I had to
So
go make
the-
a new needle.
Okay, so what do you tell your patient? They've forgotten all
Stabbed
about
myself
this
with a
tattoo
needle.
stuff that the doctor has told them.
It's a
So-
permanent mark the size of a freckle.
Because as soon as you mention tattoos, what usually comes to mind of the patient?
I'm like, oh shit,
A
free
sleeve.
tattoos?
Yeah.
Exactly. I'm like, oh, I get
Type
free
thing,
tattoos
yeah,
here
okay.
too?
Depending on their age, right? If it's an older person, that's what goes through their mind is the, I'll be looking like a tattooed sailor or something.
A
So
lot of
anyway,
older men have tattoos like
yeah,
stuff. It's pretty cool.
okay. So tell me how you go about doing a tattoo.
You put your gloves on.
Hmm?
So you put your gloves on,
Mm-hmm.
take some gauze and you put some alcohol on it.
Okay.
You take out a needle. You put some ink in the yellow part of the tip.
Okay.
You wait for it to drip down. You take your alcohol pads and you've taken the BBs off. Then you
Take the BBs off, make sure that the marks are still there. Right?
yeah, they are.
Okay.
They are.
Then you dab the mark with your alcohol pad.
Right.
Then you say, okay, it's gonna be a little stick. It's gonna be burned because that shit burns.
Depends on how you do it, but yeah, okay.
Yeah, well, when I just put it through my thumb, it burned.
Yeah.
And then I don't know, I kind of go like parallel. You're not gonna go directly into their fucking skin. That's gonna hurt.
Okay.
You go parallel and you just go into just push it right underneath the skin.
So how I would suggest you do it is you do everything you said. You take the BB off, you clean the area around, make sure you still got a little bit of the mark left. And you take your needle and you pinch a little bit of skin, put it in underneath, and then take it out. And let it go. and you'll find that that's tiny, tiny. Because you don't want it too tiny,
Oh, no.
so
it's
you can
very
see
tiny.
it. You don't want it too big, because you don't want it to look ugly.
I feel like it depends on the patient though. Sometimes when they're older and their skin is wrinkly
Yeah.
and soft, it bleeds. You know, the softer the skin, it bleeds more.
Yeah, that's why if you pinch the skin and pull it,
They always, they go, every tattoo that I've done is like very small. At first
Yeah.
I'm like, oh shit, is it too small? But
it's never too small.
then I,
Can be.
The only time that you would have a problem with the patient being tattooed too small is if it's in the middle of another tattoo. Then you would have to do something different. Because you can imagine if you have a gentleman with a tattoo right here and you're trying to change chest,
oh
and you
yeah.
have to tattoo in the middle of the tattoo, it can be a little strange.
I feel like you would choose different points, no?
You could choose a different point, or you could just put the tattoo in it and use the pen and give them a cross where the tattoo is the center, and ask them, please don't wash the marks off,
Yeah. With the little sticker.
because we'll lose your tattoo in the middle of your other tattoo. Especially if it's an older one and it's glued. So, anyway. So, we've done our tattoos, then what? You say to your patient, well, we will, depending on your protocol, someone will give you a call, make sure you have the correct phone number. Someone will give you a call with a start date, 7 business days from now. In some departments, the dosimetrist will say the plan will be ready, this is Monday, so the plan will be ready a week Wednesday, so that gives them 10 days. In the afternoon, so you go to the machine that you're going to be treating them on, and you say, can I have a new patient time for next Wednesday afternoon? Do you know if your departments have new patient times slots that are kept for new patients? You don't do that. In some departments, they keep this there's usually one in the morning around 11 o'clock, there's usually one in the afternoon around 2-ish, that they keep, and if there's no patients come in, they'll move patients up into those slots. Okay. So, you have your patient, you send them away. Now what? What are you gonna do now? You've sent the scans over to the dosimetry. Do you have anything else you need to do? Oh, we forgot one thing before we sent. What did we forget? You've done your marks, you've done your tattoos. What did we forget? Photographs.
Oh yeah, we do take pictures.
You need to take pictures.
What are you gonna do before you take them off?
Set up positioning for CT. So you make sure that all the images are there in your treatment plan. You again have setup instructions. So what kind of setup instructions might you need? This is to tell the treatment machine therapists how they're setting up the patient. So what are you going to put down on the setup instructions?
Patient positioning, all
Before, but you have to be specific. So, cervix, on the seabed, what are included in the setup instructions?
Couch index.
How your patient is lying.
Patient
How is your
supine,
patient? Patient supine. Head on,
whatever they use.
feet backlock. See photograph. Okay?
Hands on chest.
Hands on chest. Holding ring or hands clasped. See photograph. What else? Tattoos for positioning. And if you have the scenario where you have this patient with the tattoo in the middle of the tattoo, you have to explain that or show a photograph. See photograph for AP tattoo positioning. So you'd have the tattoo with pen marks around it, so it can stand out. And it's better if you can have a different color of pen. You normally use black Sharpies. If the tattoo is, the majority is blue, for example, you might want to use a red Sharpie just to outline where the tattoo is. The idea is to make it easy for the treatment machine therapists to position. Otherwise, what's going to happen? You'll get this phone call saying we have Mr. Smith or Mrs. Smith on the bed. I can't find the AP tattoo. So you have to go over and find it for them and say, look, it's right here. See the red Sharpie? Would you cover the marks with some kind of tape? Does anybody cover the marks with tape?
Stickers, clear stickers.
Clear stickers. So you might want to try that as well with the tattoo in the middle of the tattoo. Put your red Sharpie on and put a sticker on top and tell your patient, please do not wash the marks off. Okay. So this, so virtual simulation. All aspects of simulation work are performed on a 3D data set. That's the CT. Goes across to dosimetry. And once the patient gets onto the bed, the treatment bed, verification can be performed using DRRs. So here is a model of a patient. What are we treating? There. Anybody? What are we treating? Breast? Yeah, it's a breast. Tangential pair. It's got wedges, so it's not 3D. Excuse me, it is 3D, it's not IMRT. What have we got here? What do these look like?
Ribs?
Hmm?
Are they ribs?
No, they're not ribs.
Yeah, it's hard to see.
I'm not sure whether I can enlarge this or not, let me see. No, I can't, sorry. Oh, wait a minute, I can. Hang on. Where did I do it? That's just that, so let's go back, sorry. So these are needles. This is brachytherapy. You can see them here. These are the ends of these needles. So this is how you would plan the breast, or how you would look at this in dosimetry. Here's your spine here, the rib ends here, and the breast that you're treating. This is a simulator. X-ray head, image intensifier. So film goes in here, or you can also use it to do fluoro images. Fluoro images mean that you can step on a button, and it will show the images with the patient breathing. So you know that the area you want to treat is within the area that you've got on your jaws. You don't use these much anymore, but it's a nice one to see. And again, this is an updated version. So CT. Everybody's seen CT. However, you notice this is a diagnostic CT because the bed is curved. Tattoos. Everybody seen these? These are little BBs. Here's your tattoo system. And the marks on the mask. Does anybody do this anymore? Have you got marks like this on your masks?
I've seen fields drawn in, but I've never seen it squared like that. Fields were irregular shaped.
Fields are irregular shapes.
Irregular.
Yeah, irregular, yeah. So you've got a little shielding here. Depends, some physicians will just, or some departments will just say we're outlining the open fields. So that when you're positioning your patient, you want the MLCs out of the way. You can always withdraw the MLCs. Everybody knows that, right? You can actually take the MLCs out of the field. Everybody know that? So this would be the square field that you're treating, and then the MLCs will come back in. And these are the BBs, or fiducials, skin markers. And this is a fancy type of tattoo. I think I have one of those on my desk. I'll see if I can find it. So, we've gone over this. This is a, can you tell me what these are used for? This one or this one?
SRS.
Pardon?
SRS. For your brain.
The brain? What type of treatment?
SRS.
Stereotactic. Yeah, SRS. They both, this is one manufacturer and this is another manufacturer's. So they both have attachments to the skull, through the front, through the back. And this is just what they call a fluence. And this is just the fields coinciding in the one area. It wouldn't be as big as that for stereotactic. And this is another type of IGRT. And what those do is they use skin marks that are on the patient to see if the patient is moving. It's called exact track. So, this is not very good, but so this is obviously a skull, and you're treating part of this area. This is the volume that you're treating here and here. And you can see the color. This is what's called Dole's cloud. So you can see the different colors, which they should have a little, they don't, a little scale as to what the colors mean. This is all showing up on the Dosimetry scans, treatments. This is what shows up on the Dosimetry computers. Obviously, the skull is not, the top of the skull is not there because you need to see inside of what we're doing. What's this? Can you see it? The little orange thing here?
Your optic chiasm?
Yeah, the optic chiasm. Because here's one eye, here's the other eye, and you've got them both coming this way. You're the optic chiasm. So it's really difficult to see what this is, but this is brain, and this is skull. So we're treating inside here. And this is just, these are tiny fields that you'll be using. And if you look at the little guy in the center here, down here, it will show you what position the patient is in. So he is lying supine. This is a scan. So this is this way, this is this way, and this is diagonally. All sorts of straight. Just showing you what the dosimetrist would be looking at. So beam placement and shaping. Simulation film with block. So this is a lateral film, head and neck. Where's the center of the field? So here's the outline of the field. Goes right here, here, and here. There's your outline. This is your central axis, here and here. So what would we be treating here?
Base of tongue.
Base of tongue? Possibly, but you see you've got shielding here. So probably not base of tongue. Could be, I mean, this is a tongue here too. But I would say that that's probably nasopharynx. So you're treating all of this area here, and here, and the spinal cord. But then you have this dotted line that goes down here. So from there back, eventually you'll be shielding that. So what's that shielding? If you're shielding all of this after a certain dose, to start with, you'd be treating all of this, all of this, all of this, and all of this. And then at a certain dose, you would shield off this part to the back. What are you shielding? Got head and neck. You're treating the whole spine in that particular area. At a certain dose, you add this shielding. So it shields from here all the way back to the back of the field, which is here. What are you shielding? At a certain dose. It's cord, yeah, the spinal cord. So this part is base of brain. So you shield this. It's not a very good film, but here you're shielding from the beginning. Here you're shielding from the beginning. So all of that is being treated until what dose? 4,500 or close to it. And then you put this shielding in, which shields from there back. So that's what they call off cord, because you're shielding the cord. And then all you're treating is here. And in here. And this one, the DRR with conformal shielding. So here is the DRR. This is the area you're treating. These are all MLCs. You can do that with MLC as well. You don't have to do blocks. But this is MLC. So what are you shielding here? What are you treating here? It could be anything, to be honest. It could be cervix. It could be uterus. It could be prostate. There's a little lobe for the prostate down here. So it's a pelvis, basically. That's what you have to decide, whatever you're treating. Okay, so let's stop here and we'll take 20 minutes. Give Asia time to go out into the car.
I don't think I'm making 20 minutes.